Go.
Hi. My name is Anya, and I'm going to conduct an abdominal examination with you. So, like all of the other assessment, we always start with inspection. So, we inspect the patient's abdomen for shape, looking for any pulsation, any movements, pulsations from the aorta, the parasitic peristalsis or the waves of the bowels, which in a lot of times can obviously be seen. So as he takes a deep breath in and out. So that's the first, we observe, and then the next part of the abdominal assessment after the observation is auscultation. So I'm going to grab my stethoscope to listen for the bowel sounds in each quadrant of the abdomen. So you divide the abdomen into 4 quadrants, which is we're going to start with the right upper quadrant, left upper quadrant, the left lower quadrant, and then the right lower quadrant. Okay, so as you're listening, you would be noticing tingling, pinking, tinkering, pinging, or tinkering in the bowel sounds, and you should be able to listen while you auscultate the abdominal area. And then also you can listen over the spleen and over the liver for any splenic or liver or hepatic friction rub. So on the right hand side, and the splenic rubs are going to be with the use of the bell, and listen for any hepatic friction. Then move over the other side and listen for the splenic rubs. So I'm going to listen to the liver, and I can use both the diaphragm and the bell. And then the other side. Okay. And then, so next is you will go to listen in the aorta, which branches down right above the patient's abs, right over the umbilicus, with both the diaphragm and the bell. So okay, and then after that, you would like to go on listening for the splits off and listening for the iliac arteries and the renal arteries. To iliac, it then branches down further to the femoral area. So listen to the femoral artery, then to the femoral artery on the other side with you're going to be using both the bell and the diaphragm. So you're going to be listening for any vascular sounds like bruits or turbulent sounds. Iliac, and then renal, and then down to the femoral. Okay, so the next part after the auscultation is the palpation and the percussion. So percussion is a technique that requires some skill, and some practice, but generally you can take your dominant finger, your right hand middle finger, and your dominant hand, and then using the right hand, strike the distal joint of your non-dominant hand, middle finger, and it should be a quick strike. So it's like tap, tap, release. Strike and then lift up so that you don't dull the noise. So lightly you percuss on the four quadrants of the patient's belly, listening for tympanic sounds, which is the sound of a drum, because the patient's belly has a lot of air and there shouldn't be any fluid or any structures that cause it to be dull. So we'll start with the right upper, and then right lower, and then left upper, and then okay. And then next we'll be percussing the liver border. So you're going to be starting in the mid-clavicular line around the umbilicus and percuss upward until it changes from the tympanic to a dull sound. Once you hear that dull sound, you can mark that level and then you can start superiorly. So you go between the rib margins. If you percuss the ribs, they're going to be dull sounding. So you want to percuss in between the ribs until you hear that dullness. And then you want to mark that liver border. It should be anywhere between 4 to 7 centimeters. So umbilical, you just go up. And then with the rib area, you're gonna percuss in between so that you don't percuss it like, so you're gonna get that dull sound. So that's the liver border. And then you can do the same on the other side. It is harder to percuss the borders of the spleen because it's under the ribs and ribs and on the side, where you can percuss it by finding the 10th rib. So the bottom rib is the 12th rib, and then you count on the 11th and then the 10th, and then the intercostal muscle in the interior axillary, and then you can percuss the you can percuss the line on that side, and then you can feel as the patient is breathing in, and you can percuss the spleen shifting up. So there shouldn't be a splenic enlargement. So 12, 11, and then 10. And then you can percuss on that side. So there you go. Balhin na. Okay, so that's how we percuss the splenic side. And then okay, and then after that, the next part after the percussing of the abdominal is to palpate it. So you always want to start with light palpations. So using your finger, you palpate lightly with the four quadrants: the right upper quadrant, left upper quadrant, left lower quadrant, and then the right lower quadrant. This way, the light palpation makes the patient get used to my touch and gets any giggles out, and the coldness of my hands. He gets familiar with it, and then it allows the muscle of his stomach to be relaxed, that you can go ahead and do some deeper palpation right after that. Okay, mahina ari the side. Pikas. Padung sa door. using the light palpation, we can go ahead and do some deeper palpation on the right upper quadrant. When you deeply palpate for any of the structures, the main structure here is the liver and the gallbladder, right behind the liver. So you press down towards the costal margins and you can see the ribs clearly. So you want to press down, down underneath the ribs to try to feel the liver border. You can have the patient deep breathe in, and so that the liver will sometimes come down on that border and hit the tip of your fingers. Okay, Kai, as I palpate deep on that side, can you take a deep breath? Okay, 1, 2, 3. Okay. Okay. So, you can then go to the left side of side quadrant and do the same thing. So I'm going to be pressing down underneath the rib margins to see if I can feel the spleen or any splenic border. Although this is not a normal finding, I shouldn't be able to palpate the spleen because it shouldn't be, because if I'm able to palpate it, it means that the spleen is enlarged. So deep palpation against that right upper quadrant. Okay. So as I do the deep palpation, just take a deep breath in. Okay. Okay. Good. So the main structure that is down there should be on the right side is the bowel, in the left up lower quadrant. So deep palpation you're going to feel the colon, and a lot of times that can be tender. So it should not be real painful, but there is a tenderness associated with palpating that colon. Okay? Okay, good. Okay, so other techniques in feeling the liver is called the hooking technique. So on the left side of the patient, which is obviously not where the liver is, we're just gonna make a sample out of it. So you're gonna take your fingers and actually see the ribs underneath, and then I'm gonna be hooking my finger underneath that rib margins. And I will have the patient take a deep breath to feel that liver border as it comes down and bumps against my finger. So Kai, once I touch this side and do the hooking movement, can you do it? Can you make a deep breath, please? Okay, so there you go. Sorry. There you go. So another test is what we call the Murphy sign. It is a test for cholecystitis. So while you are pressing down right on the upper quadrant, and pressing for the liver, you can have the patient take a deep breath. So if the patient is, when he takes a breath and it causes him to cease his inspiration, that means that there could be some inflammation. So if the patient is unable to take a deep breath while I'm palpating deeply in that right upper quadrant, that can indicate some cholecystitis or gallbladder inflammation. So moving down the right lower quadrant. Okay, so some of the special tests you can do is to find the Ascites at the middle, or the anterior superior iliac spine, the hip bone and the anterior side, and then find the belly button or the umbilicus against the 2/3 on the way down. So between the imaginary line, the Ascites or the anterior superior iliac spine, and the umbilicus is what we call the McBurney's point in this side. So that is the part, or this is the point where the gallbladder sits below deep. Pwede ka mo ato sa middle. Deep. Pressing in, there can sometimes reveal pain, may be associated with appendicitis if the patient have other clinical symptoms. So that's the McBurney's point. So other tests that can include in this assessment is what we call the rebound test. So when you press deeply into the stomach and suddenly let go and ask the patient which hurt more, if the initial pressure hurt more, or if once you let your hands go off, that rebound hurt more. Okay, so another special test is what we call the Roth size. It's applied when you do a rebound test on the left side. So press on the left and let go suddenly. If that causes pain on the right side over the McBurney's point, then it's indicative that it should be like a potential appendicitis. So when you press over here and he feels pain on this side, that could be potentially be an appendicitis. Okay. So next test is what we call the ellipsoas sign. Also a test for appendicitis, as for peritoneal inflammation. So I will press on the patient's thigh against my hand, and I will have and then I will have the patient flex his knee a little bit and press up against with my good hand. So both guys, not yet straight and straight. Now bend your knee, okay, and then the other side. Okay, so while I'm doing that, if the patient complains of pain in that area, that also the test that can also be like indicative of a peritoneal inflammation. So the next test will be the operator sign. So I will have the patient flex his knee, and then internally and externally rotate the knee of my patient. So Kai, can you flex your knee? And then we're gonna go internally and then externally. Okay, again. And then you can also do it on the other side. Kai, flex your knee. So internally and then externally. Okay. So, so if the patient again complains of pain in that area, then yes, it's indicative that the patient possibly can have, if he has that pain in the McBurney's point, then that indicates that the patient has appendicitis or peritonitis. So there is one more series of special tests to assess for ascites. So, so percuss the borders of around the abdomen. You would expect that the protuberant abdomen would be tympanic because it will be all filled with air. So as the patient lay down, the fluid formed the ascites would shift to each lower area. So when you percuss the flank sides of the borders on each side, that will be a dull sound because that's where the fluid is. So this is where the fluid is, where the patient is laying down. So if I do percussion, then you can hear a tympanic sound. As when I do it on the side, it will be more of like a dull sound because that's where the fluid sits. Okay. So the next would be, I will have the patient roll on his side, and then when my patient has, when my patient have ascites, the fluid that was on the sides will now shift on that dependent side because the fluid goes where it is dependent. So I would again percuss the flank on the upper side, which is on the left side, and I would expect to hear like a tympanic sound because the fluid is now shifted and relaxed. Kai, can you face on your left side? Just straight. Okay. There, I'm sorry. There you go. So it's now more of like a tympanic sound because there's no fluid on that area anymore because the fluid shifted over on that side where the patient is dependent. Okay, so the last test for the ascites is what we call the fluid wave. So Kai, can you lay on your back? So if the patient has a round tuber abdomen, take the patient's hand and then press it on the midline of his abdomen, and then this is just to keep the other structures from shifting or moving around. And then once he's doing that, I would have the I will push his stomach on his right side sharply, and then I will feel it on my left hand or on the other side of my hand. Okay. So, Kai, can you do this? And then put it on that midline. Okay, and then while he's doing this, just relax over there. While he's doing this, I'm gonna press on this side sharply. And then if there's ascites, I would feel the fluid shifting on my left side of my hand. So that test is what we call the shift test, or the fluid wave test, and that's testing for ascites. Do you have any question, Kai? Okay, so that concludes the abdominal assessment. Thank you.